Good afternoon, everybody. I'm Dr. C. I know there are some of our friends who have been here before, but for the rest of our new friends, because apparently this afternoon we have approximately 460 attendees who have signed up to join us for this hour of education with myself and Dr. Melissa Teo. But as we know, sometimes last minute events and responsibilities can take us away from the computer or our handphone, and they end up missing the talk. But for your friends who have missed this talk, not to worry, because we are gonna try and put this on YouTube as a recorded video so that we can continue to permit our friends and their friends to come and learn a little bit more about this rare cancer we call vaginal cancer. So I'm just going to start off slowly, and then we let more and more people come in. If you can see from your flyer, originally it was going to be Dr. Melissa Teo starting first and then over to myself. But we made a last minute change, and I shall talk a little bit more about the overview of vaginal cancer and some systemic treatment before she goes on to the more important part, which is surgery. And I'll explain a little bit more as to why. Well, today's program, basically, I have Dr. Melissa Teo and myself. Can we just take a look at the profile, please, Li Fang? Yeah, this is myself. As I explained just now, I'm Dr. C. I'm a senior consultant medical oncologist at the Parkway Cancer Center. A lot of people who think that I'm a gynecologist, because I treat gynecologic cancer, I'm a gynecologist. I think the great difference between a medical oncologist and a gynecologist is that I don't do surgery. I purely give chemotherapy, and I actually give advice about the overall treatment and take care of the patient potentially from the beginning to the end of their of either the cancer diagnosis or their life if they actually have advanced cancer. But many patients prefer to come and see me first before they saw a surgeon, as to understand the beginning, the middle, and the end of the treatment for vaginal cancers and gynecologic cancers. Next slide, please. Melissa is a good friend, and I've known her for many number of years. So she's a brilliant surgeon. Don't be fooled by how young she looks. She's actually a very accomplished surgeon, and she was previously at the National Cancer Center, and she was a head, and she was she's still a professor to me, but and she was the head of the Division of Surgical Oncology at National Cancer Center, and she's still a visiting consultant there. She's brilliant with her hands. She's very smart. And essentially, she's here to just help me educate all of us on complex surgery for pelvic cancers. And today's topic, of course, as I mentioned, is vaginal cancer. Li Fang, can you go back 2 slides, please? Yeah. Before I continue, one more slide before. Before we continue, just some house rules. As you know, this is a one-track, one-sided webinar, meaning all microphones will be muted for attendees, but you are still able to ask your questions by sending it to the Q&A box, rather than the chat on your right side. Now, in the past, our attendees have made a mistake by putting it on the right side, and I end up missing it because I am all paying attention to the Q&A, which is at the bottom panel. If you have any questions, please go ahead and answer them. I will answer the questions along with the talk, but if I miss out some questions because there's simply no time to attend to the questions, I will bring it up live towards the end at the live Q&A. Unfortunately, there will be no opportunity for you to ask the questions live. But should you have any questions, we'll put out our emails at the end of this talk. After the talk, there will be also a review and for you to just tell us how you feel about today's talk, where we can improve, what other cancers would you like to hear about. I know a lot of people would ask me about what kind of meat to eat, what can I not eat for cancers, but those are very generic questions. And today's topic is really more on very specifically treatment of vaginal cancer. Thank you very much. And without further ado, I'm just going to share my slides and start off. So I'm going to go through it in the next 20 minutes, the overview of vaginal cancers. So vaginal cancer is rare. In fact, it's actually very rare worldwide. And in Singapore, it represents 2% of all gynecologic cancers. To put it into context, we're talking about 0.5 ladies per 100,000. That really means 200,000. We might get one person getting vaginal cancer. And here you can see this is true of worldwide. Cervical cancer is the number one gynecologic cancer, followed by uterine, ovarian, vulva, and vagina. But in Singapore, uterine and ovarian cancers are much more common than cervical cancer, vulva cancer, and vaginal cancer. There are quite a number of people who mistake between vulva cancer and vaginal cancer and cervix and uterine. Essentially, if you can see from this diagram here, the number one is our cervix, number two is our uterine, number three is our ovary, number four is the vulva, which is the outside of the vagina, and number five is, of course, the inner part, the passageway, if you have it, between the outside and our cervix. The cause of vaginal, vulva, and cervical cancer are very much the same. As to why one type of cancer is more common than the other, that unfortunately has never been explained properly by clinical studies. And we think it may never be possible to do so. Now, if we look at in context, as I mentioned, for every 200,000 ladies, they might get, we might have a vaginal cancer. This is the Singapore statistics. Breast cancer, of course, is at the top. If you see number 4, corpus uteri is uterine cancer, followed by ovarian cancer, and cervical cancer is all the way down to number 10. In fact, for a number of years, we thought cervical cancer was going to be number 11, and it will be superseded by some other cancers. But there has been some changes in that cervical cancer is again on the rise due to complacency. People think because no one gets cervical cancer in Singapore, nobody's talking about pap smears, fewer people are going for vaccinations. That's why we are beginning to see a resurgence of cervical cancer. We're also seeing a resurgence of cervical cancer in Singapore due to people not originally from Singapore, meaning they've moved from other countries to Singapore and they now become Singapore citizens, and they've never had the opportunity of having pap smears or got educated for HPV vaccination, and therefore cervical cancer is again on the rise. If we look at the etiology and the issue of this vaginal cancer, it's always difficult to put this number one at the top, which is a lower socioeconomic class. I mean, unfortunately, when we look at science and we look at looking at different groups of individuals, different people in many, many different countries, whether it's developing countries or developed first world countries, people who may have less exposure to education, may have less exposure to the knowledge of HPV vaccination and HPV infection. Therefore, unfortunately, we have to give this label called lower socioeconomic class, which means that because they live in poverty, they may have less exposure to education, they may have difficulty in knowing or getting vaccination programs, which is why if we can increase education and make it free, we can make cervical cancer screening, vaginal cancer screening and knowledge free, then this particular so-called lower socioeconomic class is never going to be a point anymore. The rest of it is HPV infection, history of genital warts, which is related to HPV infection, a chronic inflammation and infection of the vagina, which usually is for very elderly diabetic patients who could have been exposed to HPV infection, vaginal intraepithelial neoplasm, which is again primarily due to HPV infection, are all the causes of what we consider as the commonest vaginal cancer, which is squamous cell carcinoma of the vagina. Other type of cancer, adenocarcinoma, is very rare nowadays because in the 1970s, pregnant ladies used to be given a medication, which I'll share later, and that can lead to babies in their womb being exposed to high doses of estrogen, which can lead to this thing called the clear cell adenocarcinoma, which is rare, very rare now, but it is easily curable with simple chemo radiation. Because it's a rare condition, clinical trials that are specific to vaginal cancer, trying to find out why, first of all, and how to treat it is rare. It's very difficult to accrue patients for vaginal cancer treatments. Therefore, they're usually considered together as cervical cancer treatment is about the same, which is chemoradiation or surgery if it's required. So cervical cancer treatment is extrapolated to vaginal cancer, but unfortunately, again, we do not know why, but there is less chance of a success rate, meaning stage for stage, the chances of survival is lower compared to cervical cancer. Part of it is that also we used to think that because early stage, although it's associated with the best survival, is very difficult to detect. Because while we can do pap smears to detect cervical cancer, sometimes we can miss out a lesion at the bottom third of the vagina, therefore leading to difficulty in diagnosis. And very often at the beginning for vaginal cancers, the symptoms and signs are very, very subtle, very, very unusual. In the advanced stage, unfortunately, bad ulcerations, painless ulceration can lead to risk of perforation, fistulation, bowel surgery, infections. And of course, that's rather difficult and treatment is very associated with poor success rates. So we look at the worldwide statistics. Breast is always at the top. And you're looking at the vaginal cancers. This will be put online, as I mentioned, so you can slowly enlarge this if you can't see the wording. But vaginal cancers right at the bottom, way below every other cancer, way below breast, way below cervix, way below uterine, way below salivary gland, vulva, penile cancer, vaginal cancers right at the bottom. So it's really rare, but it can happen. And the different types of HPV, genotype distribution in vaginal cancers, is no different from that of cervix cancer. So if we can't really screen for vaginal cancers, then the only way we can reduce vaginal cancer is to provide the HPV vaccination. So the incidences of vaginal cancer around the world, you see this graph on the left and the graph on the right. The graph on the left is incidences and mortality. Mortality meaning how many people die from vaginal cancer. And then you see on the right, which is the red map. The red map is age standardized incidence rate. What are the chances of getting vaginal cancer? And it's very much concentrated around Asia. Asia, where it is this Indian subcontinent, Bangladesh, Sri Lanka, where the highest risk of vaginal cancer and death from vaginal cancer. And we believe that this is related to the incidences and the presence of the national vaccination program. So if we look at developed countries, most countries are now rolling out vaccination programs for both boys and girls from the age of 12 to 13, because the younger we give this HPV vaccination, we protect them against sexual debut at age of 15. So around the world, sexual debut, which means the first time they have boyfriend, girlfriends, and they decide that they're gonna experiment with sexual relations is usually at the age of 15 years old, even in Singapore. So we need to catch this risk of infection by the time they actually have sexual debut. The peak incidence of getting HPV vaccination, HPV infection, which means the commonest time to get HPV infection is at the age of 18 and 19, not any older and not any younger. So sexual debut does not mean immediately they will get an HPV infection. If I'm a 15-year-old girl or a boy and I begin to experiment and have many partners at the age of maybe 14 or 15, it will take me a couple of years to meet someone who has the infection and pass it to me. Because I'm young, I have a good immune system, I may actually convert some of that into no problems. But eventually, if I'm exposed to enough HPV, especially those that causes the cancers, eventually I will get genital warts and eventually I may get HPV related cancers in the mouth, in the vagina, in the vulva, in the cervix, and of course in the penis. So for boys and girls, to vaccinate them before they're 14 years old, we only need 2 injections rather than 3 because our immune system is high. So the program is to really catch children as young as possible. And most people ask why boys? Boys don't have vaginas. Why are we protecting them against HPV infection? because we would like to have a herd immunity. If I can protect my son, then he doesn't get infected by the girl doesn't get infected by my son. It's got very little to do with what I think my boy is going to do. It is more of a herd immunity. Now, we don't look at HPV vaccination the same way we look at hepatitis B vaccination. But hepatitis B vaccination, which can lead to liver cancer, hepatitis B infection, which can lead to liver cancer in the past, hepatitis B is also transmitted by sexual intercourse. So in that sense, all individuals who live in a developed country beyond 1970s have all have hepatitis B vaccination, but we don't look at it as something that is sex related. But for HPV, for some reason, many parents are going against giving their children the HPV vaccination, thinking that their children are going to be good boys and girls and never going to so-called have sexually transmitted conditions, and therefore they are prevented from having the vaccination. So that's bad. Now, if we look at cervical cancer in Singapore over the number of years, look at this trailing down blue line. Cervical cancer is certainly on a downward trend, but vaginal cancers have remained stable. And that's the same as on the left side, you can see the graphs from the developed countries in Australia, Norway, UK, and USA, where cervical cancer is going down, but vulvar cancer and vaginal cancer is remaining stable. Why so? We believe that at the end of the day, even with HPV vaccination, while we can reduce the risk of cervical cancer, because vaginal cancers and vulvar cancers are rarer, and the difficulty with regards to finding the diagnosis has led to these incidences. Perhaps also because generally vulvar cancers and vaginal cancers may occur to immigrants to these countries where they were never previously been exposed to pap smearing, previously been exposed to HPV vaccination. Therefore, there is increase in the incidences or remaining stable, meaning if in Australia, Norway, USA, United Kingdom, and in Singapore, cervical cancer occurs in all comers, the children who are vaccinated, therefore, they do not get cervical cancer, vulvar or vaginal cancers when they're older. Those people who end up getting the vulvar and vaginal cancers are new citizens who are maybe in their 30s or 40s where HPV vaccination is too late. Therefore, there is a higher risk of vulvar and vaginal cancer. So if we go back and see the incidences of vaginal cancers, you can see here worldwide incidence. Southeast Asia, Southern Africa, Eastern Africa, Middle Africa, Caribbean, going all the way down. In places where HPV vaccination is not part of the program, there is higher risk of HPV infection and vaginal cancers. So if you imagine if people from these countries would then migrate to Australia, to UK, and to Norway, they may be the ones who are slightly at a higher risk. This is the only way I can explain why the trends of vulvar and vaginal cancers are stable while cervical cancer is on a downward trend. So when they track very raw numbers. So key take-home message, therefore, HPV vaccination. I say this again and again, HPV vaccination is the only way we can try to prevent vaginal and vulvar cancers while the aim is at cervical cancer. Cervical cancer can be screened, but vaginal cancer and vulvar cancer is extremely difficult to screen. So looking at the subtypes of vaginal cancer, squamous cell carcinoma, which is the one that is related to HPV infection, develop in the cells lining the vagina, usually in the area closest to the cervix because of the same infection risk. Peak age is at 60. It spreads by local blood and lymphatics, and it starts by having this thin squamous cell lining the vagina, which is very difficult to tell, and it usually grows slowly over many years. But we're seeing that changing over the last few years in that younger and younger ladies are getting vaginal cancers. Clear cell adenocarcinoma is in 5 to 20%, develops from the mucus producing cells of the vagina. The peak age is at 19, generally because of the blood spread associated with in utero exposure to DES. As I mentioned before, in the 1950s, the drug DES was given to some pregnant ladies to prevent miscarriage, and they therefore unfortunately exposed their baby child in utero to that, and these young ladies would develop a clear cell adenocarcinoma at the age of 19 to 20. The prognosis is generally extremely good. However, for those who present very late, they can present and they can spread to the lungs and lymph nodes, and therefore prognosis will be poor. So understanding that there is a chance of getting vaginal cancer at a very young age, if their mothers were in the 1950s, 1960s, were born in 1950s, 1960, I think is the best chance of survival. Looking at the subtypes of the rare cancers, melanoma requires a melanoma of the vagina, and sarcomas of the vagina requires, and it deserves a bit of discussion here, mainly because melanoma, which used to be a very difficult disease to treat, is now a much easier disease to treat because of immunotherapy or checkpoint inhibitors, which I'll share a little later. Sarcomas are rare, but it can happen, especially in children, peak age at 3, and this is highly sensitive to treatment. And embryonal sarcomas, while it's rare, presents very fast with grape-like type of lesions in the vagina in our children. And if they don't mention it, we don't know, it becomes very difficult to treat. But mothers need to be aware, while it's very, very rare, of course, it can happen. So the issues with vaginal cancer, as mentioned, early disease is difficult to detect, usually best by screening, but is notoriously difficult. I mentioned the word screening here because many ladies who have previously been infected by HPV, especially 16 and 18, had their cervix removed. They chose not to see their gynecologist anymore, but they need to, and they need to continue to have regular Vault smears. If they have regular Vault smears, we can still detect and screen for vaginal cancers. Late disease associated with symptoms. Dr. Teo will mention a little bit more about the symptoms, so I will not go into further detail here. As mentioned, treated in the same principle as cervical cancer. Early stage is radiation or surgery, depending on the age and depending on the size of the tumor and where it's present. Again, Melissa will dive deeper into that. I will focus the next few slides on the late stage treatment with chemotherapy, immunotherapy, and this thing called radiosensitizers. The concept is important because chemotherapy, everybody knows, is a type of treatment that is usually given intravenously that can kill tumor cells, but can also, of course, cause a little bit of hair loss, cause nausea, cause vomiting, cause the blood counts to go down low. But in vaginal cancers, majority of the chemotherapy is given as a low dose, as a radio sensitizer, meaning to make the tumor cells more sensitive to radiation therapy. Combining the radiation therapy with radio sensitizers may kill more tumor cells. Yeah. Now, the last, of course, is immunotherapy, which is a treatment that uses the patient's immune system to fight cancer. This is now known more as checkpoint inhibitors. The survival of vaginal cancer, of course, the earlier stage it is, the better the survival, as I mentioned here before. A little bit about melanoma. If I were to mention vaginal melanoma, most people would say, we've never heard of that before. You've not heard of it because melanoma is otherwise known as skin cancer. So some doctors would explain and say, you've got skin cancer at the vagina. People will start looking, go, huh? Can you say that again? I normally know skin cancer to be this black spot on the mole. People ask, doctors say, pay attention to your mole. If your mole becomes very itchy, then come and see us. But there are two types of so-called melanoma. There's the Western type that occurs in pale skin individuals or fairer skin individuals. And then there is the Asian type of melanoma, which is slightly different. And in Asians, we tend to get, even though it's rare, we tend to get a greater proportion of this type of melanoma called mucosal melanoma. Mucosal melanoma means it occurs not traditionally in our skin, but in the mucosa, which could be our mouth, our eyes, the vulva, the vagina, the GI tract, the anus, and the rectum. Now, nobody's going to start looking in their mouth for black spots. Nobody knows that there is melanoma there. Very different from the Western type of melanoma where we can see a black spot changing in shape and size and therefore seeking medical attention. So which is why for vaginal cancer and vaginal melanoma, it develops rather late and difficult to treat. So mucosal melanoma is very rare, accounting for 1.4% of all melanomas and only 0.03% of all new cancer diagnoses. It represents 2 to 5% of all melanomas of gynecologic organs and only 0.3 to 0.8% of malignant melanomas. But we do see it. The traditional treatment was surgery followed by radiation, but despite surgery followed by radiation, the spread of the cancer is very highly likely and the risk of recurrence is extremely high. It is usually unpigmented. So again, if doctors are not aware, they end up saying, oh, this is not a problem. It's just because you're postmenopausal, the discharge will disappear. But it takes a experienced gynecologist to say, hey, that looks funny. Let's biopsy it and make sure it's not a melanoma. It can also, of course, be pigmented. Conventional therapy is associated with 15% to 20% chance of response, and the chemotherapy used listed as below: dacarbazine, cisplatin, paclitaxel, liposomal paclitaxel, doxorubicin, and so forth. But they're all associated with low chance of response until we had interferon and interleukin, which is associated with a better chance of response, but toxicities were very important. Now, melanomas happens to be a type of cancer which is related to our immune system. The better our immune system is, the better the chance of response. So interferon, interleukin is exactly what our immune system produces in order to kill viruses and kill cells. So with that, of course, if we have a better immune response, followed by taking interferon and interleukin, we can treat this cancer. So this new concept called the immunotherapy or checkpoint inhibitors is where we actually amass our T cells to kill the cancer cells. I'll share a little bit more. So in a way, the vagina is not a really sun-exposed area because it's in the mucosa. And therefore, mutations can be found. So we generally, again, associate skin cancer with, I go under the sun for too long, therefore I get skin cancer. But nobody ever really exposes their vagina to the sun. So we need to be aware that it can happen, but it's got very little or nothing due to the sun. Looking at the historical timelines of therapies in advanced cervical cancer, again, this is extrapolated to the treatment of vaginal cancer. We really only know how to treat cervical cancer from the 1980s onwards. Radiotherapy, discovery of HPV viruses, chemoradiation, followed by high-risk HPV testing, co-testing, and eventually now, of course, Gardasil 9, which is a very good HPV vaccination, is now available. Treatment of cervical cancer also includes targeted therapy and immunotherapy, checkpoint inhibitors. The treatment of cervical cancer is below: paclitaxel, docetaxel, common chemotherapy. This also is the same for vaginal cancers, but none of this is really associated with a complete response. The best chance of response from chemotherapy for advanced cancer is at best 50 to 70%, but the risk of it coming back again is quite high. We therefore look for the better treatments, such as chemoradiation for early stage, and of course, adding this targeted therapy called Avastin to any chemotherapy. Again, as I mentioned, this is a study that where we added Avastin to chemotherapy for stage 4 cervical cancer, we will get a better response and a better chance of survival. We translate that into vaginal cancer. Unfortunately, the response is the same, but the progression-free, meaning the remission period, is a lot less. So moving forward to immunotherapy using checkpoint inhibition, if you've not heard of this concept, I'll share a little bit about the mechanism of action. Basically, the T cell is what kills viruses and cancer cells in our body. It is a very powerful white cell, and this powerful white cell can be depleted in people with HIV infections, with chronic diabetes, with chronic illnesses. So when we talk about immune system, we're really talking about these memory T cells, which can kill and can support our body even when there are early tumor cells. There is this stain called PD-L1, which if a tumor cell has it, it is able to escape from killing by our T cells. So checkpoint inhibition or immunotherapy, if the tumor cell stains PD-L1, the checkpoint inhibition can remove this inhibition to the point whereby the T cell can now recognize the tumor cell and kill it. So why we respond well to it. So cancer cells, as I mentioned, can develop many mutations that can make them foreign to the immune system. Don't know how to recognize it, don't know how to kill. So now, of course, T cells can recognize, attack, and kill these cancer cells if the PD-L1 is switched off. There are many studies that have done in cervical cancer again. Reason I mentioned before, because vaginal cancer is so rare. But in cervical cancer, there are multiple studies that show that there is high expression of PD-L1 in up to 96% of cervical carcinoma tissues or squamous cell. And it's the same thing we say about vaginal cancers. If we see a patient with early or late stage vaginal cancer, we send the disease off, the tumor off, for looking for expression of PD-L1 in case the cancer comes back and we can treat with immune checkpoints. Unfortunately, again, treatment with immunotherapy is similar to cervical cancer, but response is not clearly as great as that of cervical cancer. Again, we cannot explain why, but it is a treatment modality. This checkpoint inhibition is also very good in melanoma cases, not just in skin melanoma, traditional skin melanoma, but also in mucosal melanoma. This is an example of a patient with stage 4 skin cancer that was given anti-PD-L checkpoint inhibition and a good period of disease control. But after 2 years, the disease came back. And of course, then they have to have double, this thing you see on the right side here is actually double dual blockade, which means that we give 2 types of anti-PD-L1. Now, to put things into context, if you look at the number of years in between the treatment here, it may not seem to be very long. But until checkpoint inhibition came along, treatment of melanoma was extremely difficult. We saw patients with vaginal cancer, vaginal melanoma living for less than 6 months from diagnosis, but now with checkpoint inhibition, it is greater than 2, even 3, even 4 years. So we are changing paradigms. Of course, there has to be more studies that have to be made, but at least we're improving the survival and the progression-free of patients with vaginal melanoma. A little bit about rhabdomyosarcoma, which is not really my area of specialty because majority of the time this occurs in children at the age of 3. It is a highly malignant tumor that presents like this. I'm sorry for the bad picture, but it is extremely, extremely sensitive to chemotherapy. So when we see a child like this, immediately we give them urgent chemotherapy under the guidance of a pediatric oncologist, and the chances of cure is very high. So the treatment regimen for a vaginal sarcoma or rhabdomyosarcoma is multimodality. We can shrink it, followed by surgery and or radiation, followed by more chemotherapy. So in the conclusion, in cervical cancer, in vaginal cancer, it is all, if not all, related to HPV. It is very rare, but there's an increase in younger women lately due to the lack of HPV vaccination. It is not easy to screen and detect at early stage, and treatment is not easy as is usually found in late stage, and surgery is often debilitating and sometimes rejected by unconventional therapy such as complementary medicine, which then of course leads to poorer survival. So prevention is definitely better than cure, but what comes next is, of course, Melissa is going to share with us some of the treatment modalities, surgical, that can make the treatment a bit more complete and without chemotherapy and radiation. So with that, I'm going to hand over the mic to Melissa, and I will continue to answer some questions from the Q&A. Thank you very much for your attention.
Okay, thanks, Hui Ti. Let me just start the video and share my screen. Thanks for the introduction. And again, thanks for involving me in this afternoon's talk. I'm going to share my screen here. I will not obviously go through a lot of the introduction that you've already done so. Not sure why. Have you stopped sharing your screen?
I've stopped. You go ahead.
Okay, trying to do that, but for some reason or other, it's not allowing me to do so, which is strange. We did test this quite a while. Okay. I have my slides here, but hang on. Can you all see still not able to share my screen? Okay, I'll try it one more time. Security. Okay, maybe you take some questions first and I will try to see if you take some questions first, I'll see why this is not sharing screen. Give me a minute.
Okay, well, while Melissa is trying to set up, I apologize about this. I'm going to answer the questions live. So here we have the first question. If a young woman has already done radical hysterectomy, is HRT required, or HRT may increase the risk of cancer? Now, if I'm a young lady, by young, I mean below 40 years old, and I'm not ready for menopause, and I've done a radical hysterectomy, but my ovaries are intact, then I do not need hormone replacement therapy. But if I've done a radical hysterectomy with the ovaries removed and I'm younger than 45, I may want to consider a short course of hormone replacement therapy, which would then be would reduce my risk of osteoporosis and heart problems. However, while I'm on HRT, I will need to be very careful with my breast examination. I need to go for screening mammograms, screening ultrasounds to make sure that there is no increased risk of breast cancer. So generally speaking, HRT is not saying whether it's required or mandatory. It is good to discuss with the gynecologist as to how long I need the HRT for. It doesn't necessarily increase the risk of cancer if given for a very short time. But for a lady to turn postmenopausal at the age of 45 due to surgery isn't really too young. So at 45, a lady may choose not to take hormone replacement therapy. The next question is, what are the signs and symptoms for vaginal cancer? Dr. Teo will explain a bit more detail in a while. The next question is, up to what age should one have HPV vaccination? I answered this question many times, and it still is quite a amusing part for me, because we advise ladies and gentlemen to get their vaccinations when they are 12 and 14, purely because it's 2 injections versus 3 injections. So it's cheaper. That's number one. Number two, the immunity seems to be kept lifelong, especially now with the Gardasil 9, which is a very, very powerful vaccination. Now, in fact, for my son, we threatened him to do the vaccination. Nobody likes to have injections. So when we threatened him to do the vaccination, we told him if he does it before he turns 14, he only has to have 2 jabs. And that's why he's completely vaccinated now. There is no upper end of the age. But if I'm only going to get married and have my sexual debut when I'm 60 years old, then sure, I should have the HPV vaccination, even when I'm 59. But if I were to get married at the age of 20 and I don't get vaccinated, but I continue to have multiple partners until I'm 45, then the point is moot, because I may have been exposed to the HPV already. So there is no end age. But if I had a lady who's 45, she's not thinking of having a boyfriend, never going to get married, never going to have an active sexual life, then there is not absolutely compulsory to do HPV vaccination, especially if they've been tested pap smear to be negative for HPV infection. So there is no upper age. It's as soon as possible. We don't ask this question of chickenpox, polio, and others. Okay, so Melissa's slides are on now. I'm just going to go back to answering the questions online while she continues with her talk. Melissa, over to you.
Okay, here we go. Close that. Can you hear me, guys? Just there you go.
Good. Everything's good. Please go ahead.
Okay, so is off now. Let's go. Okay, I'm sorry about that. It was tested multiple times, but all right. Taking over from where Hui left off, we've gone through the etiology, but I generally wanted to just say, when we see these patients, obviously sometimes we find them incidentally, and sometimes, as advised, when patients go for routine cervical screening, they are picked up to have abnormalities on the screening or a mass within the vagina. But often the patient presents to us when they have bleeding, intermenstrual, or they have pain, either pain that is there spontaneously or pain after sexual intercourse. Sometimes they present with a very large lump. Actually, when I get involved, most of the time it's when a gynae-oncologist says there is a big mass and it looks like it might be involving a whole bunch of stuff, and maybe we can have a look at this together. So I think one of the ways to start and look at this to make it a little bit easier for everyone to understand is to look at the pelvic anatomy. As you can imagine, the vagina, which is cited here, is situated between many organs within the pelvis. You have the rectum and anus behind, and obviously the cervix and uterus on the top. And in front, there is the urethra and the bladder. And all of these organs are sited within a very confined space. So if a person has a large mass in that area, then potentially many of these organs would be involved. The local extent of the disease can spread along the mucosa upwards to the cervix, downwards to the vulva, and obviously they can have extension to the surrounding organs, as I mentioned previously. Um, in fact, I would say most of the time when a person presents with what is thought to be a vaginal cancer, it actually probably is a cervical cancer that has extended downwards, or a vulval cancer that has extended into the vaginal canal. Be that as it may, it is important to understand the natural history and pattern of spread. We saw the direct extension of this mass into the surrounding structures, but also important to understand the lymphatic drainage. So all the organs that we come across have a lymphatic drainage. And as with all the other cancers, an assessment of whether there is nodal disease is important. And in the vaginal cancers, these are the stations of disease or lymph nodes that we are concerned with. Within the pelvis itself, we have the pelvic lymph nodes, and those can go along the internal as well as external iliac vessels. We also have lymph nodes situated at the obturator canal. And obviously, these lymph nodes can extend more proximally into the common iliac and presacral and para-aortic area. But in addition, especially for vaginal cancers that are in the lower third, you can have nodal disease or extension into the lymph nodes within the groin. So these are known as the inguinal lymph nodes. And when we assess the extent of the patient's disease, we would want to see if there is a disease involvement of these areas. So traditionally we always talk about TNM staging for most cancers, and there is also a TNM staging of vaginal cancer. Although with gynecological cancers, I have to say, majority of the time the FIGO staging is more commonly used. And if you look at the FIGO staging here, it's interesting because FIGO 1 is tumor confined to the vagina, 2 when it goes to the paravaginal tissues, and 3 when it goes to the pelvic wall, 4A when it goes to the surrounding organs. But 3 also could be a regional, which means pelvic or inguinal lymph node metastasis. And it is sort of important to distinguish between the two. Clearly, a patient that has stage 4B has a poor prognosis because distant metastasis is not good in any cancer, particularly so for these squamous cell cancers. So this is a pictorial diagram of the depth of invasion, but I think suffice to know that if it is fairly early on stage, we are talking about 0, 1, maybe up to 2, but once it gets to the surrounding organs, stage 4, or to the nodal metastasis within and outside the pelvis, this is considered advanced staging. And this is important because when we counsel our patients, we want to give them a rough idea of their prognosis. Patients that have early stage cancers have a much better survival compared to patients that have distant metastasis. And you can see here the 5-year overall survival from the SEER database for patients with distant mets is 20%. So as PT had mentioned, in early stage, we can consider surgery. And surgery is also considered when after radiation, if a patient were to go for radiation, there remains a persistent tumor. In some of the non-epithelial tumors, like the stage 1 clear cell adenocarcinomas, that can have a good prognosis, surgery with clear margins might be what we would advocate from get-go. Obviously, when we are planning the kind of treatment, and if you look at the NCCN guidelines, there isn't actually a category for vaginal cancers per se. There is treatment options for cervical cancer as well as for vulval cancer. And so the treatment of vaginal cancers falls somewhere in between these two. The considerations are fairly similar. We always want to know what the stage of the disease is. We want to know the size. We want to know the involvement of the surrounding organs of the local extent. We want to know the nodal involvement I mentioned. But also we want to know functionality of the vagina and how we're going to achieve that. When we think about radiation, and I'm not sure if they're radiation oncologists, the radiation is very useful for treating many of these squamous cell carcinomas. Obviously, we also have to be cognizant of the potential side effects. These include fistulas, and the fistula can be formed between any two cavities, so rectum and vagina, or the bladder and vagina, or there can be also strictures. And I've seen, I guess, quite a few patients who have had these strictures. There can, of course, be cystitis and proctitis, and so the patient presents with either hematuria or perorectal bleeding. And in some of these young women with vaginal cancers, they can have premature menopause. So these are considerations. How about surgery? As we mentioned, for the early stage cancers, definitely a wide local excision, but clear margins are obviously what we would want to attain in any of these resections. In the upper part of the vagina, the resection often would entail removing the uterus, having clear margins coming right down to the lower part of the vagina, and also a pelvic lymph node clearance. But in the lower third, then we are talking about removing that part of the vaginal canal and possibly the vulva at the end of it. And then reconstruction of the vagina, which I will go through later on. So in the later stage, I guess, apart from chemotherapy, which Hui has gone through, external beam radiation therapy with or without brachytherapy is often also employed. And if there is radiation, the dosage is normally about 65 to 70 grays, and they would tend to include the regional lymph nodes in that area of radiation. And obviously concurrent chemo-RT as a a radiosensitizer. But a lot of these are small case series, as you can imagine, because vaginal cancers are not that common. Now we're leading up to some of the gory pictures, and I want to warn everybody, it's kind of like adult supervision only. I hope you guys haven't had lunch like me, because if you have, you might want to blanco out or turn away for a while. The following few slides may cause disturbance of your sleep for many nights. When we talk about pelvic exenteration, and now we are moving really away from that kind of limited local excision of a tiny little lesion in the vaginal canal, but we are talking about the tumors that really in the stage 4A category or the stage 3 category, where the tumors come out from the vaginal canal and potentially involve many other things. Often this has been explored, and initially this was explored around the region of 1948 for cervical cancer. It is pretty radical, and the extent of surgery is obviously dependent on what are the organs that are involved. And then you are left with this huge cavity that we have to try to reconstruct and repair, because you can't have the patient walking around with this huge defect. So pelvic exenterations are also done for locally advanced rectal and anal cancers, but definitely any of the locally advanced gynecological cancers or urological cancers are also to be considered, and I've also had to do them for pelvic sarcomas. There are different types of exenterations, and it really, again, like I said, depends on what kind of organs are involved. But if the tumors are involving mostly the anterior, so you have an anterior wall of the vagina cancer, you may not need to resect the rectum. The patient may not need to have a stoma from that GI point of view, but the bladder might end up having to be removed, and we might have to think about options for reconstruction of the bladder and urological structures. But if the patient has a posteriorly based vaginal cancer, then we would be looking at a posterior exenteration where they might end up having to have a resection of the rectum and anal canal and end up with a colostomy. So the considerations, I guess, we always take a complete history from the patient. We want to identify the symptoms. You also want to identify, how mobile they are, how functionally fit they are, how sexually active they were, as well as if they have any other comorbidities. As with any cancer, we want to know if the disease remains local, regional, and if they are not, then doing a big surgery, a big whack that may have a certain amount of morbidity and maybe debilitating is not the way to go. Systemic options is much better in terms of palliation. Now, I often get a PET CT to ensure that we don't have metastatic disease, but the MRI pelvis is important because it allows me to look at the extent of the tumor and involvement of all the structures that I mentioned before. Very often, especially in an Asian patient, they want to know if you're going to operate around that area, if they're going to end up with a permanent stoma. And I think this is something that I always try to answer from get-go. These are some of the blood tests that we might want to employ, and nutrition is important. And I'll talk to you a little bit about why many of these patients have had radiation before, and this is a radiation failure or a recurrent disease. And in the primary disease, they already receive the maximum tolerated dose of radiation. So you really want to ensure that you have all the factors boosted up in order that they can recover quickly and well from this surgery. So I'm sorry for the gory pictures. Now, this is not quite a vaginal cancer, but you can see that these are the structures involved. This patient had a sarcoma actually that was very near the anal canal, but it ended up involving also the vaginal canal, and we had to resect the whole of that. Now, the MRI, as I was mentioning here, tells you many things. And on the axial cuts like this, the transverse cuts, you can see if anteriorly, what are the structures that are involved, going all the way to the front, the urological structures, and going all the way to the back, even the sacrum if it is a really locally advanced tumor. And the lateral extent of the tumor needs to be determined as well. The coronal cuts will allow you to see if there is sacral involvement, not so common in vaginal cancers, but in some of the other pelvic tumors. So this is what I mean by a coronal cut. And you can see in this particular patient, the spine or the vertebral column, the sacrum and all that is well clear, but everything around the perineum probably has to go, which means even the urethra, because you can see disease creeping up here. Certainly the bowel and the anus would have to go. And this patient would be looking at potentially an exenteration with 2 permanent stomas. So these are the things that I was mentioning. The MRI is very useful for that. I write here to assess the potential resectability because to me, there is no point in pursuing surgery if we cannot be fairly confident that we're going to be able to get a negative margin. And of course, the MRI helps in planning the operation. Now, I talked about margins, and this concept has often been explored in rectal cancers, proximal distal margins. But I think any cancers within the pelvis, the circumferential margin is desperately important. And if we're going to be leaving a positive margin, I'm not sure that that is the way to go. And again, we might be looking at other forms on other modalities for treatment that may be less debilitating. So this is the separation of the Kaplan-Meier curves, showing that if you had a positive margin, probably might not even want to do surgery there. Of course, if the patient is unfit or unwilling, we would not drag a screaming patient to the OR. There are other contraindications, I would say, distant metastasis that also include periodic notes for vaginal cancers. And if in any patient who has got sacral involvement very high up in the sacrum, we worry about permanent neurological damage. Even if the extension of the tumor is all the way to the sides, going down to the sciatic notch, involving the sciatic nerve, that might not be a good prognostic factor, and you might want to shy away from surgery. There are other relative contraindications, and this is not because it is not possible to do the surgery, but it tells us about tumor biology. If a person has got bilateral tumor encasement of the iliac vessels from a vaginal or cervical cancer, that's probably no good. But bilateral uretary obstruction, I wouldn't be so quick to write a patient off. So if you look at this picture, this is not quite vaginal, but if you look at it, I points for anyone who can identify. So you go back to the picture here, you see air in the bladder, and I guess in medical school we've all learned air in the bladder is a bad thing. It tells us that there is a fistula, and true enough, after resecting, you can see that the tumor has invaded and involved more than half the wall of the bladder here. Again, apologies for the gory pictures. But urological reconstruction can be done if it's a little, if it's, I would say, less than 25, 30%, a partial cystectomy, we can still close it primarily. But I think if the bladder is going to be taken, a significant portion, and it doesn't make sense anymore functionally to just close it up, then the urologist often comes and helps with a bunch of things, which include things like ileal conduit creation if we do a total cystectomy. If the ureter is involved only on one side, then you can do either a primary reimplantation or a Bowery flap, depending on the length of ureter that needs to be resected. We mentioned just now that vaginal cancers often are treated like cervical cancer. And I think I see this especially in the recurrent setting. So many of these patients have had radiation before, and despite the radiation, they come back. And so we think about whether there's anything that we can do, because it is quite a miserable death. They have a mass there that may be fungating through. They also often present with bilateral flank pain, and you can understand why, because the mass will grow and it will involve the bilateral uretary orifices. So this is a patient, I will always remember her because I operated on her more than 10 years ago when I was a younger consultant. And if you look at her scan, it's a tiny little thing there, and you wouldn't imagine there would be anything terribly significant. She had cervical cancer that was treated in the usual fashion, radiation, and then she recurred. When she recurred, I think her primary surgeon said, okay, I don't think there's anything that we can do. So anyway, she was sent to an oncologist who spoke to her about systemic treatment. And this was, like I said, many years ago, more than 10 years ago. She rejected it. And so it was kind of thought to be palliation all the way. She was only known to me because she felt a breast lump about 9 months later and presented to a breast surgeon who rang me up and said, "Hey, Mel, I'm not going to take out the breast lump if you think like this is truly palliative, and this the what is the prognosis like?" And I looked at it, and this is what I saw: this tiny little thing here that can barely be picked up on the MRI. But also interestingly, she had bilateral hydronephrosis, and that tumor at the cervix that had been radiated. So there was also some stricturing and all that had pulled the ureters into the center, and she was now threatening to go into renal failure. So we went in and we did a total pelvic exenteration, and you can see here, and I show this picture not because I want to add another gory picture to this whole presentation, but apart from the fact that every single organ in the pelvis is cleared out, I want you to see the tissues here. They have been heavily irradiated, as is usually the case when patients receive radiation for cervical cancer, and quite fibrotic. So obviously we needed to try to find out how we can fill up this space, which sort of leads me to the second part of my talk: reconstruction post-pelvic surgery. So we have a huge defect after these surgeries, and we've cleared out everything. And as I mentioned, patients would have had extensive radiation. Some of them would need to start on systemic therapy, and we want to get them recovered as soon as possible and on with their lives. So we want to restore anatomy. It is important, and some of these women can be quite young, and you think about how to get them back to where they were and feeling pretty normal again. We want to bring fresh tissue into an irradiated and exaggerated pelvis to reduce the dead space and then all the complications, such that collections that get infected and all that stuff that prevent them from starting adjuvant therapy. And there are a couple of options. So I mentioned them here. I think the next page later on, I will go through some of the other flap options. And in the female patient, the specific well, these are all female patients, I guess, but the specific considerations are: how much did we have to take? Was it a total vaginectomy? Did it include a vulvectomy, the labia, minora, majora? Did they all have to go? Do we have to reconstruct that? How do we fill up the pelvis so that the abdominal organs, such as the small bowel, doesn't fall into the pelvis again, and then we end up with all the problems of, intestinal obstruction? And if we have to give additional booster radiation in some of these patients, if the small bowel is within the pelvis, that gets us that makes it very difficult to deliver radiation. We also don't want the small bowel loops to herniate through the pelvic wound. We want the wound to heal as quickly as possible. So there are many, many different options for flaps. Personally, I'm not a plastic surgeon. I do pedicle flaps, but only really the robust ones. Some of the more finicky ones, the free flaps and all that, I mean, my colleagues, the plastic surgeons, are way, way better. They do this very well. But I like to use these pedicle flaps because, it's so robust, and it adds half an hour or so to the surgery, and we fill up the entire pelvis. So a grassless flap, and I don't often use this except for maybe some small rectovaginal fistulas. We harvest the muscle and the skin from the inner aspect of the thigh, the muscle being the grassless muscle. We tunnel it inside, and then we fit it here. Another gory picture coming up soon. So this is the thigh. This is the vagina. So this would be the left thigh, and you can take quite a big pedicle of pedal of skin as well as fat subcutaneous tissue with the underlying muscle, and then this is divided and it's turned inwards underneath the skin to reconstruct. This patient, it has it on the right hand side of the thigh. The muscle is harvested, is threaded underneath this bridge of tissue, and then stitched in place to create sort of the posterior wall of the vagina. This is bilateral. I'm sorry for this poor quality picture. This one is a stock photo. Bilateral, and it looks terrible here, but once you close up the thigh wound, this flap was used to recreate the labia, majora, minora, and vaginal canal. So quite useful. But I think my favorite is the VRAM flap, which is a vertical rectus flap. I use it for so many things, but the pelvic surgery being one of them, because it provides such a nice pedal of skin and muscle, and it's just about enough to fill up the entire pelvis. So we take this and we incise along this that I've drawn here. This is the inferior epigastric artery, which we have to protect like hell. We divide the superior epigastric artery and the rest of the stuff here, and then we mobilize all of this, and we flip it over and drop it into the pelvis, and then this is closed up primarily, and we look at what we have in the morning. So this is how it looks like. This is the length, and I sometimes have to measure to make sure that it goes all around. we make sure that we keep the inferior epigastric artery there, and we drop it into the pelvis. So this is another patient, probably, oh, that patient that we operated on just now. She was alive without evidence of recurrence more than 10 years. I mean, I haven't seen her for a few years, but I continued to follow because I've left NCC. But I followed her up for more than 10 years with no recurrence. And really, it was just to remind me that, we sometimes we shouldn't give up on the patients. So this is another patient with a tumor in the perineum, again, involving pretty much all the structures there, and the mass involving the cervix and the loop of small bowel. So this is the tumor. It looks less impressive taken out, but the tumor, the vaginal canal, and then cervix, loop of small bowel. So it came out in one piece, clear margins. This is a rectus flap that I use. It looks like a very big pedal here. This is sort of the umbilicus, I guess. I could have taken that away, but it looks very big. But I did want to bring some fresh tissue, and maybe we could have trimmed it a little bit more. But this will all change, and the color will be quite similar after a while. Remember this picture because I'll show you something that's a little bit different later on. So just now we talked about creation of a new vagina. The vertical ram flap that I showed you just now was really just to drop it in, and it formed part of the wall of the vagina. But actually, if you look at the pictures here, we can actually tubularize the last part of that rectus flap to make it into a tube. And we did that for a patient here, which again I operated some time ago. She had a recurrence. This is the vaginal canal, the cervix, the anus, the rectum, and the tumor was coming out. She was having diffuse thickening on the vagina. There was a communication between the two. So she kept having poop coming through the vaginal canal. It looks gory because the whole perineum had to be taken out, the tumor going to the vagina. And if you open up, you can see actually that gap and that communication between the two. And that's where I was trying to show the communication. But it is also a rectus flap that I use, but you can see how different it is because this patient had such a huge mass that the whole rectus flap was used to fill up the pelvis. And I only needed part of the pedicle to form the posterior wall of the vagina here. And interestingly, as with most of these things, even for the ones in the mouth, right, buccal, and you put a muscle flap inside there, after a while, it epithelializes so that it looks quite mucosalized. Even though this is actually skin, it has become like this over a period of a couple of months. So I want to end off with another kind of flap. And this got my interest, I don't know, 6, 7, 8 years ago. I heard Chu Chip from Chulalongkorn give a talk, and he was talking about how in Bangkok, and he had to do a lot of accentuations, but also he was asked by the gynecologist who did a lot of sex change operations in Bangkok if there was any way he could give them a segment of the sigmoid colon, because they were thinking that it might be quite a good new vagina for the men who wanted to have a sex change to become women. And so he was doing it for them for a while. And then he thought, why am I doing it for benign cases like this? But why don't I use it after an accentuation? I thought this is brilliant because now you're using the patient's own organ and an organ that has got mucosa already to create this. So I then sent one of my young consultants and convinced her that, a couple of months of som tam and thigh massages is not a bad way to go. And came back and employed her knowledge. And then we have done quite a few cases together. So this talks about taking a segment of the sigmoid colon and without dividing the vascular pedicle, you just harvest a length of maybe 8 centimeters or so, open it up, and there you are. You already have immediately sort of a new vagina that can be stitched down. We spatulate the end because it eventually does contract down. And if you look here, this is the new vagina with an opening, and this is really just the sigmoid flap. The only main problem is that there is a fair amount of mucus that comes down because while the sigmoid colon is alive and does produce some mucus, it is of course disconnected in terms of the bowel continuity from the proximal colon and from the GI tract. But what is maintained is the vascular supply. So this is my last slide. And the last slide is to talk about lymph node assessment. I talked about it earlier on. I'm often asked to do this. So with the vaginal SCCs, we often just get a PET CT and see if there's anything that's suspicious. And if there is nodal disease, we would do straight on immediately a lymph node dissection where we clear all the lymph nodes in the femoral triangle, keeping, of course, the femoral vein, the femoral artery. But Huiti mentioned two other things that I am also particularly interested in, which are melanomas and sarcomas. I've been asked to assist with a few gynecologists when they have found vaginal melanomas, and what we do is we inject the vaginal canal with a tracer, and then we see where it goes to, and we try to remove that. Um, so if it is in the groin, then we make a tiny little incision and we excise that sentinel lymph node to see if it has been involved by metastatic melanoma. If it is within the pelvis, we tell the patient that we would have to try and harvest that lymph node there. And of course, for melanoma, we talk about MSLT2 studies and whether there is a need to carry on with regional node dissection if it is positive, and obviously if it's negative, then that's all that is required. There's probably a lot more, and I've given talks to the Skin Cancer Society on sentinel lymph node and the groin and regional node dissection. So I don't think we have time to go through that today. I'm sorry again for the gross pictures and for speeding through the talk. Be happy to take any questions. Preeti, I hand this over to you.
Thank you very much. Thanks, Melissa, for the very extensive discussion on exenteration.
Okay, let
For,
me
for
stop.
all our audiences here,
Okay.
while the photos are very gory, I have to categorically say that exenteration is an older form of treatment which has been given a new life, in the sense that the type of surgery that you see Melissa do here is not the common day surgery that we do day to day to day. We do try to prevent vaginal cancers and vulvar cancers with HPV vaccination. For the rare incidences where we still see this cancer, chemoradiation is the mainstay of treatment, followed by more chemo. So why do we even have such debilitating surgery? Why is it necessary? For some of our patients, we do find that the cancer does not spread. It cannot spread and it won't spread. That's a good thing. But the patient's quality of life is poor because the cancer just stays at the same place for the longest time, years and years and years. And when our patients hear the word years, it's good because they can live for a very long time, but they live sometimes in pain. So a surgery as such, which may be potentially disfiguring, permits us to get rid of the cancer so that the patient does not need chronic chemotherapy, chronic radiation, and they can actually have a fairly good quality of life. So for the photos and the patients that you have seen in Melissa's slides, they are not the usual day-to-day patients we see. These are patients who have learned how to live with a recurrent cancer and wishes to have a way of just solving the problem in the local area in the vagina and being able to leave hospital, leave the clinic, and live a fairly normal life. So after failure of chemoradiation, we're talking about even rarer number of patients. We maybe see one, maybe two. If we saw three in a year, it is already considered as a bummer, meaning too many. So eventually, for patients who actually would benefit from such a surgery, they are carefully selected and after much extensive discussion. But it remains to be a very good mortality of treatment for patients who have failed conventional therapy. It's now 3:10. We are already bus time. I think we're already losing some of our participants. I just have to say that I'm just going to take 3 more questions, and then the rest of the questions we're going to have to direct it on our Facebook or to the emails. The 3 questions that are left in the live, there's only one question that is related to vaginal cancer, and that's for patients who have had vaginal surgery and recovered, how is their quality of life passing urine bank going back to spots? And I think I will get Melissa to answer that. The other 2 questions, if a patient has severe eczema, will their skin be suitable to harvest for skin replacement or restoration purposes? That is also, I'm going to let Melissa answer that. The last one is, I will answer it privately. Melissa, over to you.
Okay, so I think quality of life is a great question, and in fact, we ran quite a lot of quality of life studies when I was at NCC, because to me, we want to be able to give that patient obviously prolongation of life, but it doesn't make sense if they are miserable. And I think that's also in our assessment of the patient's suitability. I think we have to understand what they have lived with, what are the symptoms that they are experiencing now, and if we can improve that. So if I can give the patient a benefit of not just prolonged survival, but also improve quality of life, because now they have this big mass that's coming out, that's painful, that's bleeding every other day. They have to wear a pad and change it every couple of hours. Then definitely the quality of life is going to be improved. But I would say many of these patients, and the patient that I was mentioning just now, as well as the patients offhand anecdotally that I can think of doing that I've done a pelvic exenteration for, their quality of life, they are like any other normal person. They walk about, they go on long walks, they go to the market, nobody would know that they would have had this. But I think also because we have picked our patients fairly well. So that's one. The second question was about severe eczema. I think a lot of it is also, if a patient has severe eczema, I will work very closely with a dermatologist. It also depends, therefore, on the skin pedal. Sometimes patients require a big muscle bout, but the amount of skin that is required, like what I showed you in the second or third patient, is actually not that much. So we can still harvest that muscle flap with a little skin pedal. But clearly, if the patient has got a huge defect that requires a lot of skin and the skin condition is not good, then we might have to think of other things. We can still harvest the muscle flap with a subcutaneous thing and then leave that subcutaneous layer to just granulate. And that also works well. You don't really need the skin in that sense. So yeah, the short answer to this question, Delphine, is yes.
Melissa, there's a last question for you. Unfortunately, we have to take this as the last question, talking about dealing with VIN3 many years after radiation post-Wertheim for CA cervix.
Yeah, so I think again, if the patient has very localized, it sounds very localized VIN3, but has already had radical radiation, then I would think that a surgical option should be explored, because you're not going to treat that with systemic therapy and the patient has exhausted the radiation options. I would think and consider carefully about surgery.
So thank you very much, everybody, for your attendance. We're going to close the webinar shortly, but please do not forget to give us your feedback so that we can improve. Unfortunately, there's been some questions about Wi-Fi connection, and the whole talk was breaking up or can't hear us. That would be a problem with Wi-Fi on your side or with the equipment on your side. Sometimes if you can't hear, please use the headphones. But other than that, we've put this on our Facebook and you can re-watch it at your leisure time for a number of months. And please do share this with people whom you think is going to benefit. With that, I'm going to close this webinar. Thank you very much, Melissa. Thank you very much for our participants. Please share with us how you felt we have done. Thank you very much. Goodbye.
Thank you.